please let me know that you can see my slides, so I can start the presentation. So is everything okay?
Yes, we're all good, Dr. Emiliano. Please go ahead.
Okay, so again, thank you very much. This is my first virtual time in Vietnam. Please, I would like to visit your country because I know that it's a lovely country. So before starting the CO2 angiography trip that we have in our center, we always need to know why we should start something new. And the whys are multiples. The very important is that CO2 is non-allergenic, non-toxic. It is a main indication in case of allergy to iodine contrast media, can reduce the volume of ICM used and post-operative creatine levels. It is an additional tool in complex EVAR and also can shorten both operative and fluoroscopy time. Also can detect endoleaks, and in some papers it has been implied in cost reduction of the entire procedure. But why CO2 angiography is still not widely utilized? Because first of all, it's not standardized. It depends on the operator, device, and the application use. There is an exaggerated fear of complications and also an unfounded assumption that is time-consuming and produces inferior quality imaging. Another point is that there is the need to reduce the use of ICM because worldwide there is an ICM shortage. So our experience, we started with CO2 angiography in 2014, and this is all the application from peripheral intervention, AV fistula, EVAR, complex EVAR, renal, visceral intervention, endoleak. And to do that, we should use the automatic carbon dioxide injector from AngioDroid. And so we focus this paper today with the aortic procedure because it is the most widely utilized in our center and the most studied with a lot of literature on that. When you do EVAR, we should not use diagnostic catheter. Instead, introduce a sheath more than 6 French. And also you have to standardize the amount of CO2 in 100 milliliter and with a pressure between 650 to 750. Very important, when you do such big injection, you should wait 2 minutes for safety reasons. So this is an image, a typical image of CO2 angiography. Very important is the post-processing imaging. So you do the angio and then you do a new remask and then stack in software in order to visualize, in this case, the renal artery with the yellow marker and the pink marker for the left renal artery. So you can now deploy your device very safely. We have published our multi-center prospective study on the European Journal, and this is a very interesting paper because we have standardized the procedure. We have also standardized all the possible maneuvers that we can do in order to visualize all target vessels. So the procedural success was 100%. The zero contrast EVAR, so no drop of ICM, was done in 82% of our patients. 30-day mortality was 0.4%, and no visceral renal artery occlusion and no high flow endoleaks. If we use ICM, it was used in 53 patients, 18% of our patients. The median volume of contrast was 20 milliliters, so it was very few drops of contrast. No major events, only minor, as you can see here, 1%. And we are going to present next week on Boston our midterm result of the prospective study, and we can say that nearly 20% of these patients have a renal deterioration in case of ICM administration, which is nearly 20% more. Also, on the Kaplan-Meier curves are 2 years, you can see that the CO2 has an advantage versus the CO2 plus ICM in EVAR procedures. Also, we use CO2 in rupture aortic aneurysm, like in this case, you can see the bubble outside the aneurysm, and you can see very well the hypogastric artery, the renal artery, as you can see in these 2 figures. Then at the end, you can check if everything is fine. This This EVAR was performed with just 300 milliliters CO2, no contrast, and also the follow-up was without contrast, without CT scan, with contrast enhanced ultrasound. We published our series, which is the largest worldwide, for ruptured anerism. But also CO2 angiography can be problem solving in case, for example, this patient with a previous EVAR in another hospital, but they overstented both renal arteries. The right one was occluded and the left one had tight stenosis. So we needed to rescue the left kidney without contrast for sure, because the patient was still in the borderline for dialysis. And you can see how beautiful are the imaging with the CO2. And this is the before and this is afterwards with the deployment of the stent with the guidance of CO2. And so the patient had a decrease in serum creatinine and also the reduction in medical therapy because of the nephrovascular hypertension. Also, you can guide endoleak treatment. You see here in the visualization of the rheolana arch with a macrocatheter in the rheolana arch. You can see the nidus, you can see also the lumbar arteries, the sacral artery, and you can guide the entire procedure with CO2. Also, these two imaging are the same patient with the same projection, and the A is contrast, but B is CO2, and you can see that only with the CO2 you can see the type 2 endoleak. So in my mind, CO2 angiography is always better than ICM. And you can also perform final angiography as in this case, and you can depict very well the type 2 endoleak. Also the CO2 CBCT can be performed and visualized at the end of the intervention, the type 2 endoleak. Our current and future project is to do zero contrast AAA diagnosis, treatment, and follow-up, from planning to follow-up. And how to do that? You can do MRI plus CT scan without contrast, color duplex ultrasound for access, then during the operation, CO2 angiography, and then postoperatively, contrast enhanced ultrasound, plain abdominal radiography, and CT only on demand. And this is an example of a case planned and performed without zero contrast, and so also the follow-up was uneventful. We can do also complex EVAR. This is a scheme of what we do as a standardized approach from preoperative planning to final 3, the verification. And just an example, this is a pararenal AAA, which was, in this case, the CT scan was done with contrast because the patient had a normal function, but then we decided to skip on with a zero contrast approach. And here is the fever, which was from Terumo. And so you can see here the angiography. You can see the CO2 going in all the vessels, like the superior mesenteric artery marked with green and with the orange marker for the renal artery. And now we are ready to deploy the 4th fenestrated graft. And you can see that the graft is very easily deployed with a marker in front of the fenestrations, and now we are ready to cannulate all the visceral vessels. And you can see how beautiful are the imaging with selective cannulation of the superior mesenteric artery in order not to cover the first collateral. And then you can enter the left renal artery. You can see here the check of the left renal artery with the CO2, the patency of the vessel, now the stenting of the superior mesenteric artery, and then the check of the vessel, which is open, no complication, and then finally the right renal artery, which is cannulated and flared with a B flare, and then finally the celiac trunk. This is the cannulation with a stirruple catheter, and now you see we are in the hepatic artery. You can see very well the hepatic artery, and at this point we can deliver the bridging stent in the 4th fenestration, and then the check for the final angio, and you can see all the vessel patent. At the end, we can do the CBCT, and this is the image that you can find with the CO2 CBCT. in my mind, are very beautiful. Both renal arteries are patent. The superior mesenteric artery is patent as well. And this is the final reconstruction of the case. In order to check all our intervention without ICM, at 12 months we did a CT scan and everything was perfect. And final issue is the radiation protection for CO2. We know that there are diagnostic reference levels for standard EVAR, and they were tested with ICM. For example, in Italy, the threshold is 160 Gray square centimeter. And so we look with multiple publications of the dose after CO2 angiography in EVAR. There are a little bit of difference among different centers in our prospective national study, but what we see is that the radiation dose can be optimized for CO2 EVAR. And how? You need to use the modern angiography system, low dose CO2 protocols, and also CO2 DSA synchronization. This is our example in our center. We started with the Siemens whole device, Siemens RTZ, with a standard dose. And this was the dosimetry for CO2 EVAR. And the median was 65. Then we skipped with the same Siemens RTC, but with a low dose protocol, and we dropped to 40. Then we acquired the Philips Azurion 7 device, the new angiographer, and with the standard device, you have here that the median dose is 31. So we are doing every year, well, better and better. But we are not happy because we know that we should have the low dose as much as possible. This is the parameter that we set in our machines. So, is it possible to do better? Yes, for sure. The first optimization was to use the automatic injector synchronized with X-ray machine. So you press the foot pedal, the CO2 starts immediately, but the X-ray will follow according to the delay. Just an example, this was a thoracoabdominal aneurysm. We do this synchronization, and you can see the beautiful image of the aorta, marker for the renal artery, marker for the superior mesenteric artery, and the celiac tract. In this case, the patient didn't have the right kidney before because he had cancer. So here you can see the decrease in DAP with this optimization, 14% reduction, and also the low dose. This is the same patient with the same projection, but one of these two images is a low dose. And what does mean low dose? Means that we have with this image 46 reduction in DAP, and here are the numbers. So with the evaluation on 20 patients, we have a significant decrease in DAP for the low dose protocol of 48%. Just an example, the DAP for this 3-modular standard EVAR, 500 milliliter of CO2, no contrast at all, we have 1/5 lower than the recommended guidelines for standard EVAR. So finally, take-home message is that CO2 angiography is safe and effective in different clinical scenarios. It is complementary to ICM. It can be very often be used alone. We need to reduce ICM usage not only for patients, but only for the environment. We need to reduce nephrotoxicity and for our vascular patients. For sure, it is required a learning curve and material knowledge, and CO2 education is a key point. So thank you very much. I would like to invite some of the youngest vascular surgeon in Vietnam to this nice event for just 20 participants, very focused on endolit masterclass and also for CO2 angiography. Thank you very much.